Good afternoon. Thank you for joining us for the webinar, Best Practices for Successful Reentry for People with Opioid Addiction. My name is Mark Stovall. I'm a policy analyst at the Council of State Governments Justice Center, and I will be moderating today's webinar, which is hosted by the National Reentry Resource Center. For the webinar today, we're excited to have two other panelists join us. We have Andre Bethia, who is Policy Advisor for Corrections at the Bureau of Justice Assistance in the U.S. Department of Justice, and we also have Jack Charlier, who is National Director for Justice Initiatives at the Center for Health and Justice at TASC. And to introduce them quickly a little bit more, Andre is Policy Advisor for Corrections at BJA. Previously, Andre served as the Director for Program Operations and Policy at the New York City Department of Correction, where he managed external relationships with community-based organizations and research institutions, as well as developed policy curriculum, identified best practices, and supervised programmatic initiatives for adolescents and young adults in custody. Andre's career in criminal justice began as an analyst for the New York City Police Department, but he also previously worked as a legal coordinator and provided law library and research services for people in custody at New York City Department of Correction. He has a BA in criminal justice from John Jay College of Criminal Justice and an MA in library and information science from Pratt Institute. And Jack Charlier leads criminal justice consulting and training services for the Center for Health and Justice at Treatment Alternatives for Safe Communities, or TASC. He specializes in criminal justice policy and civic engagement, including developing strategies and solutions that lie at the intersection of criminal justice, behavioral health, and the community. He previously spent 16 years of service in the State Parole Division of the Illinois Department of Corrections. As Deputy Chief of the Northern Region, he led system-wide parole operations for the Chicago metropolitan area. Jack also served as the Criminal Justice Representative for the Institutional Review Board at the University of Illinois Chicago and is an adjunct faculty member at several Chicago area universities where he teaches criminal justice courses around ethics, leadership, research, and management. He has an MPA from The Ohio State University and a BS in mathematics from University of Illinois Urbana. Thanks to both of you for joining us today on the webinar. For an overview of today's webinar, first we will provide some information on the Bureau of Justice Assistance, the Council of State Governments Justice Center, and the National Reentry Resource Center. And then we'll provide some data for context for the opioid epidemic and how it intersects with the criminal justice system. Then we'll hear from Jack Charlier and myself about key evidence-based practices for successful reentry for people with opioid addictions. And at the end of the webinar, we'll have time for questions and answers. And just for some housekeeping items before we get started, at any time during the webinar, you can ask a question by typing it into the Q&A panel on the bottom right-hand portion of your screen. This includes both technical and content-related questions. We will try to reply to technical questions in the chat window as we go. For the content-related questions, we will keep a running list and address them all at the end of the webinar. We will do our best to get through as many questions as possible. If you encounter technical or audio problems during this webinar, please call WebEx Technical Support at 1-866-229-3239. And please understand that there are some technical issues that you may not be able to resolve. And so for this reason, we are recording this webinar, and we will post it to our website at csgjusticecenter.org/NRC. We should have the webinar posted online by the end of next week. And now I'm going to turn things over to Andre Bethia, who will talk a little bit more about the Bureau of Justice Assistance.
Thanks, Mark. Good afternoon. My name is Andre Bethia, and I am the Policy Advisor for the Second Chance Act, Reentry Improving Reentry for Adults with Co-occurring Substance Abuse and Mental Illness in the Policy Office at the Bureau of Justice Assistance, or BJA. At BJA, our mission is to provide leadership and services in grants administration and criminal justice policy development to state, local, and tribal jurisdictions. Specifically, BJA provides funding to support law enforcement, combat violent and drug-related crime, and combat victimization. Through the development and implementation of policy, services, and sound grants management, BJA strengthens the nation's criminal justice system and restores security in communities. I will now turn things back to Mark to continue with the introduction.
Thanks, Andre. And now I'm going to give some background information on the Council of State Governments Justice Center and the National Reentry Resource Center. So the Justice Center is a national nonprofit, nonpartisan organization that serves policymakers at the local, state, and federal levels from all branches of government. Staff provides practical, nonpartisan advice and evidence-based, consensus-driven strategies to increase public safety and strengthen communities. And here you can see some examples of the publications that we've done over the years in content areas such as justice reinvestment, reentry and employment, law enforcement, and behavioral health. And the Justice Center operates the National Reentry Resource Center, or NRRC for short, in partnership with the Bureau of Justice Assistance. And since 2009, the NRRC has provided technical assistance to more than 600 grantees. The NRRC also serves as a source for user-friendly, interactive information on best practices in reentry. We are always adding new content to our website, and we send out a monthly newsletter that provides information about the latest research, funding opportunities, webinars, and other news about reentry. To sign up for the NRRC newsletter and other newsletters, please visit the link on your screen at the end of today's webinar. And now I'm going to turn things over to Jack Charlier, who will talk more about the opioid crisis and how it affects the criminal justice system.
Thank you, Mark, and good afternoon, everybody. My name is Jack Charlier, and it is a pleasure to be with you today as we continue the discussion that's been going on in the United States now for many years around how we as professionals in the fields in which we work can help people re-enter society successfully from jails or prisons who have opioid use disorder and help them avoid overdose and overdose death and move on with their lives and get into recovery. It's a pleasure to be here, and I look forward to your questions after the webinar is ended. So we're going to start off with just some background on the opioid epidemic. One thing you should know is I generally don't read slides, so I'm going to ask you to kind of make sure you're paying attention and following along to what's on the screen. I'll just point some things out. We wanted to start off with a level-setting infographic, so this is it. And what I'm going to ask you to do is just take about 10 seconds. I'm going to stop talking, take about 10 seconds, and read over this. We want to make sure that you have some of the background stats that are going on. And I'm going to ask you in that time that I give you to look at two stats in particular that you find the most interesting, and you're going to choose what those are. So let me pause and just let you read this slide because it's chock full of super important stats that you need to know about the opioid epidemic. Okay, and of course you'll have available to you these slides afterwards, but it's important if we're working at this time in this place right now that we do understand that there's a reason we're attaching the word epidemic to opioids, and this infographic lets us know that the numbers we're seeing, the lives lost, the lives affected, the families affected, and how our systems are being affected, behavioral health, criminal justice, is on a proportion that we've never seen before in the United States. And that's super important for you to know, and so just make sure you've got two of these stats in your head and keep them in mind when you get in discussions with people or you think about your work and why it's so vitally important that we're putting so much attention and so many resources from the local to federal level into combating the opioid epidemic and the importance of your role for people reentering who have opioid use disorder. So let's dive in on the next few slides to some of the specifics on here. Again, I won't read the slides, I'll just point some things out. On the second bullet point, or the second item on here, is really a big takeaway for all of us working on this, that of course we are focused on the epidemic, but what we also know for the justice population is that they're often polysubstance users. And so if you look at that second item there, that's not news to any of us who are working in the field. So while resources are correctly coming in to combat the opioid epidemic, to save lives, to reduce overdose, the impact on families and children, and all the attendant issues that go with someone who has an opioid use disorder, we keep in mind the larger work that we're doing, of course, which is treating addiction, right? Treating addiction. This chart shows you, this is not specific to opioids, this chart shows you drug overdose deaths in the United States. And so the blue line is for the entire United States, and then of course the orange line is just for specific jurisdictions that information was gathered from. The thing to note here, of course, is that the line is trending up very slowly. And so you just said, well, Jack, you said this is an epidemic. This is really focusing lots of attention. Me and my jurisdiction, we're doing a lot of this. This is kind of a slow trend line up. If you look at the time period, it's not very long. And when we get to the next slide, you'll see then, if you have not seen this before, this trend line, how much of it is being caused by opiate use. So now look at the trend lines that are going on here, and unlike the curve we just saw in terms of all overdose deaths in the United States, look at this. These are overdose deaths just from opioids. And the green line, of course, is all the opioids combined. So when we think about this as an epidemic, even though that trend line looked kind of a smooth, kind of slowly going uphill, which we don't want that anyway, this is the underlying cause of why we are seeing that trend line go up in the United States. It is because of opioids, and these are very, very steep trend lines. The other thing I want you to notice on here, so look at the green line again, that's all opioids, and just think back to one slide when you're looking at that slow, gradual increasing line of all overdose deaths, not just opioids. The other thing I want you to notice on here is the gray line at the bottom, which is methadone. Methadone is also, of course, one of the 3 accepted medication-assisted treatments for dealing with opioids. And notice how low that is. And so while we know that there is a risk of death, overdose and death involving methadone, look at that and the arguments that are often made about it, when it really is a very, very effective medication when prescribed correctly and monitored correctly. Look at that compared to everything else. It's a huge asset to us in fighting this epidemic. When we think about the epidemic, and certainly in criminal justice, which is dominated by men in the criminal justice system, your local jurisdiction, state, nationally, we're getting really, really good now at making sure that we're always thinking through, well, what's the impact on women? And so here you see some information about the opioid epidemic and women. I'll draw your attention to the third bullet point down again, speaking to the scale and the scope of this epidemic. When we see that for women, this has never, ever been higher. That's a big deal. And it's a big deal because women, as we know from our experience in the criminal justice system, they are the ones who are holding families together more often than not. They are the ones who had custody of the kids prior to reentry, and upon reentry will get the kids back at some point, if not fairly quickly. And so for the consideration of women on reentry, we must always keep children and families in mind. And then also, again, this slide just showing the devastation, especially for women, that the epidemic is causing. So successful reentry practices around opioid addiction for all, to be sure, but when it comes to women, we need to pay special attention to the impact it's had on them in large proportion, and the fact, again, that they're going to be the ones who really will be looking after the kids and caring for the family, often alone, not always, but often alone, and we want to be mindful of that when we construct our reentry practices. This slide here gives you a sense of what the opioid epidemic looks like for criminal justice population at the state level and in your jails at your local county and parish level that we all work with. And again, to this idea that you see on here is that the population we work with is polysubstance. There's other things going on with them, but because of the increased likelihood of overdose and overdose death, due to the nature of how heroin function, how opioids function, we pay special attention to it. But again, we see that the population we have has polysubstance issues going on. And by the way, these statistics, as I think all of you are aware, these statistics compared to the U.S. population in general are much, much higher in all regards as they are for criminal justice, whether it's serious mental illness, SMI, SUD, substance use disorders in general, regular mental health issues, communicable diseases, whatever it may be. Our population, of course, has these at rates that are not seen in the U.S. General population. This slide really gives the important item on here, the main item on here, really is a study that many of us use that came out before the opioid epidemic actually started, in the sense that of the growing awareness around it and the national attention on it, I should say. Communities already were dealing with it, to be sure, and that is the middle of that first bullet point, what happens on the first 2 weeks of release. And so this is why we talk about reentry for people with opioid addiction in particular as needing special practices, special effort, special policy, special training, special relationships because of this increased heightened risk of overdose and overdose death. And of course, we know, if you're familiar with this study, that that risk of overdose death is actually higher than risk of homicide, for example. And so when we think about the communities where many people who are in the criminal justice system are returning to, right, a small number of zip codes in a larger city or village or county, sometimes these zip codes also have attendant issues around other types of violence or criminal activity. And so if you think about this, again, from an epidemic standpoint, that the risk of overdosing and dying from that versus homicide, that's even higher. Homicide is less than that. Overdose is higher, again, giving you a sense of what the epidemic looks like. Good. And with that said, then, I will turn it back over to Mark.
Thank you, Jack, and thank you so much for providing that data. It really speaks to the implications for public health and for public safety. So now I'm going to outline the best practices quickly, and then Jack and I will spend some time delving into each practice and walking you through each one. And I want to note that the practices outlined here in this webinar will also be reflected in a fact sheet that's forthcoming from the National Reentry Resource Center. We plan to have the fact sheet published on our website by the end of next week. And so everyone who registered for this webinar will receive an announcement once the fact sheet is ready, and also if you subscribe to our newsletters, you'll receive the announcement as well. So when considering best practices for reentry for people with opioid addictions, there are four main categories into which the best practices can be grouped. The first is planning and coordination. This involves identifying, screening, and assessing to find out who has opioid addiction. It also involves inreach by community-based providers or other social service agencies, as well as by probation and parole officers if applicable. And it involves the development of case plans to help ensure that reentry and recovery are successful in the community. The second group is behavioral health treatment, and this includes counseling, behavioral therapy, and medication-assisted treatment, or MAT or MAT, for opioid addictions. And along with this, there should be cognitive interventions to address other criminogenic needs, meaning individual characteristics that can increase the likelihood of criminal activity, such as criminal thinking and antisocial peers. The third group is probation and parole. Probation and parole officers play a critical role in supervising people who have opioid addiction and who are returning to the community from incarceration. And in some jurisdictions, these officers provide case management, and they may even be part of specialized caseloads for substance use disorders and for people with opioid addiction. And then the fourth and last group is recovery support services, housing, and other supports in the community. And because recovery is an individualized process, the services and supports offered here will vary from person to person. But most typically, recovery support services include things such as education and vocational training, supported employment, peer-led services, and case management. Housing is also a very important consideration for people who have opioid addictions and who are reentering from incarceration, especially options for safe and stable housing and housing placements that accept people who are taking MAT for their opioid addiction. So the first several best practices that fall under planning and coordination are screening, withdrawal management, and assessment. Many times these practices will be done upon intake to the correctional facility. Sometimes they don't happen at intake and they happen later, closer to discharge from the facility. Screening should take place as soon as possible upon intake into the correctional facility to identify whether someone has signs of opioid addiction or physical dependence or is experiencing withdrawal. Correctional facilities should establish processes to refer people who screen positive to receive a full substance addiction assessment, and the assessment determines the scope and nature of people's behavioral health needs. The assessment results also inform what kind of addiction treatment services should be continued upon the person's return to the community. And I should note that on July 10th, a few weeks ago, we held a webinar on screening and assessment for opioid addiction in the criminal justice system. And we're sending a link to that webinar right now as a resource on the topic. And because of high rates of co-occurring mental illness along with opioid addiction in correctional systems, correctional facilities should have a screening and assessment process in place for mental illness as well. And we also have a webinar that goes over this topic in further detail for screening and assessment for co-occurring disorders. And I believe we're sending the link to that webinar as well. And then if someone is experiencing withdrawal from opioids, the person's withdrawal symptoms need to be monitored for the person's own health and safety, as well as for the safety of correctional staff and inmates at the correctional facility. Correctional facilities should have processes in place to ensure that withdrawal symptoms are managed safely and to help prepare people for addiction treatment when appropriate. And in September, we will be hosting a webinar on this topic, withdrawal management in correctional facilities, with Dr. Kelly Clark, who is president of the American Society of Addiction Medicine. And so the next several practices under planning and coordination have to do with in-reach by community-based entities and case planning, including relapse prevention plans. A collaborative comprehensive case plan should be developed before people are released from the correctional facility. Staff from either the community-based treatment provider, probation or parole, or from the correctional facility can take the lead in the case planning process. And so the purpose of these plans is to make sure that all entities involved in the person's reentry and recovery give input into the plan and have access to information in that plan, and that the plan addresses both criminogenic and behavioral health needs. These plans should also include referrals and connections to ongoing treatment and recovery support services. And so some specific considerations for people with opioid addiction include information about whether the person is taking medication-assisted treatment, what their housing situation will look like upon release from corrections, and what kind of recovery supports the person will need upon release. The National Reentry Resource Center has a webpage specifically about collaborative comprehensive case plans with information about key components and priorities for the plans, as well as profiles of agencies from around the country that feature different kinds of lead case planners, whether that's correctional facilities, community-based treatment providers, or probation and parole agencies. And then a relapse prevention plan should be developed before release from the correctional facility. In some cases, this plan will be part of the collaborative comprehensive case plan. The relapse plan should include relapse prevention plan, should include identification of the person's triggers for relapse, how to avoid these triggers, and how to manage impulses. In addition, the person's family and/or support system should be engaged in the development of the relapse prevention plan to ensure that they are aware of the person's triggers, their impulses and cues, and how to help if the person relapses or overdoses after release from a correctional facility. And then the last 2 points are overdose prevention materials and naloxone kits, as well as information sharing. People leaving correctional facilities, as well as their pro-social friends and supportive family members, should also receive materials on overdose prevention and, when possible, be provided with naloxone kits to help reverse the effects of a potential overdose from opioids. Naloxone reverses the effects of overdose from opioids, and it can be administered by anyone. After receiving naloxone, the person who experienced the overdose should get medical attention and be referred to or re-engaged in treatment for opioid addiction. And information sharing is critical to make sure that everyone knows what's going on with a person's reentry and recovery. There are several types of information that can be shared with different entities with proper consent given, including medical history, history of substance use and addiction treatment, and history of mental illness and treatment for mental illness. It is important that programs make arrangements to protect confidential health information. Federal laws and regulations are in place to protect the confidentiality of the sensitive information that relates to opioid use and other health issues. The Health Insurance Portability and Accountability Act, or HIPAA, and Title 42 of the Code of Federal Regulations, CFR, Part 2, provide guidance about the conditions under which protected health information can be shared. It's important for agencies and entities involved in a person's reentry to understand these guidelines and to work collaboratively to share relevant information with each other and to reduce duplication of effort when gathering information. And so now I'm going to hand things back over to Jack, who will go through the rest of the best practices.
Good. Thank you, Mark. Really, really good job on that. I learned something from each webinar, whether certainly when I'm participating, but even when I'm presenting. So really, really good job in going over that. Let's get going now, as Mark said, on some more of the best practices. So on here, we're going to dive into each of these points for a few seconds each, because these are really, really important to understand. Why? Because the intervention that is going to address the opioid use disorder is the behavior health and the recovery intervention, and that's what this slide is getting at. In other words, if we did everything else, and we know this, right, but if we did everything else structurally well, by policy well, and we didn't do the behavior health intervention well, we would end up right at the same point that we started, which was an individual who's very much in need of treatment and whose life is probably not at a good place at that point in time. So we'll start off then with the first one, which of course is medication-assisted treatment. And the idea here is that in your jurisdictions, you want to make sure that you have access to all three medications. Do you have access to all three medications? I don't know. More likely than not, you have one for sure, maybe two, possibly not three. But the goal here is access to all three medications, and that's both whether the person, of course, is inside the jail and prison, and then on continuity of care when they get into the community. So in terms of a takeaway from this first bullet point is what MAT options you have and how can you work towards, from a systems perspective, getting all three MAT options on board. And remember, MAT is a decision between a patient and their medical provider, so their medical doctor. It's not one where parole, probation, wardens, treatment providers are to be making. It's to be done between the patient and the doctor that they are seeing. So that's the big thing on MAT, and of course MAT's sole role is to cut the cravings, right, to address the cravings that a person feels so they're stable enough to do the second point, and that is individual and group counseling. And so while we have relied a long time in community corrections on IOP and OP in the community setting, and certainly this exists to some extent in prisons and jails. We know the percentages are not very high. The number that is often cited from the federal level is 11%, 12% of people who are inside of institutions, jails, or prisons actually are accessing treatment. We know on the community side it's much higher. Again, just like MAT, you want to work to increase the options, but you also want to make sure that you have continuity of care from inside to outside. Remember the stat that we just had right before the section marked it that talked about the increase of overdose, which is really overdose death, which is also about overdose, and the substantially higher rate that exists for someone coming out of jail or prison, which is really about coming out of an environment where they have been abstinent. And so if someone's been abstinent for a variety of reasons, that could be going into a residential treatment program, into detox, those same kind of risks exist. Abstinence to community where there are no boundaries, there are no walls, and all things are available. So we want to think about the first two bullet points again in terms of continuity between inside and outside, inside being prison and jail, outside of course being the community. And we want to think about how do we ensure the narrowest gap, if there's any gap, on the connection of MAT to cut the cravings, and then the individual and group counseling that's needed so that as they transition to community, they're well-versed prior to that point on all the things that go with that in terms of education, triggers, cues, and then when they get to community, they have that rapid wraparound support that they need as they encounter, again, a world of options that they didn't have while they're on the inside. And then, of course, that naturally leads then into evidence-based treatment, which is cognitive behavioral therapies. And so when we're talking about using community-based treatment, of course, you want to make sure that you're using sites and programs that, in fact, acknowledge and use CBT. And that's super important. So when we think about the base of evidence, we want medication-assisted treatment, we want counseling, and then we want CBT. And the combination of those three is what gets us our biggest bang for buck proposition on reduced drug use, handoff into recovery, and then of course reduced drug use, handoff to recovery means less crime, less contact with the criminal justice system, well-being, jobs, schools, family, all that coming back into play as the person stabilizes and can function again over time, right? And then, of course, that goes right into the next one, which we've talked about a little bit already, which is this idea of continuity of treatment. And this is one where there's a lot of struggle that goes on around what happens in a prison, say, in the community, whereas the Department of Corrections of a state can control a lot of what goes on in a prison. It can't control it in the community. But we know with this population, as we've seen already, how important that is, certainly for everybody upon reentry, since that's a topic today, but especially for the population because of the likelihood, the increased likelihood of overdose and overdose death. So continuity of treatment, how narrow can that gap be between the counselors and the correction officers and the treatment staff on the inside to the outside? Can we get that down to just minutes where someone literally leaves, walks through the gate or the door, and right there is the next person who says, "Hi Jack, I'm here to be with you, and by the way, Jack already met me when Jack was in the prison or in the jail and knows me. They have my plan. It's all worked out. First 2 weeks are all mapped out for me. I know what's going to happen, and I knew about it ahead of time." And that those folks on the outside are communicating back to the folks on the inside. There's sometimes this idea that the sharing of information doesn't kind of have a lot of relevance, but it really does, especially as people reenter community and begin to exhibit behaviors or patterns that the person on the outside says, "You know, I need to call back to the folks on the inside and see what do they know about this. Did they ever mention anything about this? Did it come up?" So that continuity is super important, and we know that, again, especially for this population. So when you think about this, maximize MAT to cut the cravings, the individual and group counseling inside and outside. And on MAT, if you can do the pre-release induction, I think I missed this first time around, if you can do pre-release induction, that is good. That helps then, especially in the first 30 or 60 days when someone gets out. And then think about the group counseling. How can I marry those two up from inside to outside? Am I using evidence-based treatment? Do we have that on the inside? Do we have it on the outside? Are we in this abstinence-only kind of space on the outside, or can we find folks who are able to deliver the evidence-based treatment that's needed? And, of course, continuity. So that's what we're talking about here. There's much more that we would go into if we were on site with you or talking to you on the phone, but these four elements and then getting into recovery really speak to the specificity of the practice you must have in order to reduce overdose and overdose deaths for this population. We'll go next to key players in the reentry movement, of course, and always are, which is probation and parole. The idea of training for folks here really isn't about just kind of some general knowledge about addiction, but it's also the neuroscience of addiction, treatment, how treatment works, why does treatment work, what are the evidence-based practices about treatment. This is nothing new to probation and parole, but it also includes now, and so if your probation and parole officers haven't been trained on this and gone through a real good, solid, probably 2 to 3 day course of the items I just mentioned, they should, and if you can get that going, if not. But also, when we're dealing with opioids, we have to make sure that probation and parole officers are doing things like carrying naloxone, right, and know how to administer naloxone, know how to work with their local law enforcement for first responders and emergency rooms to address this, can train on naloxone for the clients on their caseload, know how to access it and help their clients access it, and ideally their families to access it too, so they have naloxone in the house. That's something parole and probation has not done generally. Of course, neither has law enforcement, neither has other entities within the justice system. So probation and parole needs good neuroscience, treatment, understanding the science behind medication-assisted treatment. In particular, this is not one drug for the other, a common thing I hear when I work with probation and parole. It's not one drug for another. It's a drug versus a medication. Very different things. The evidence-based practices, naloxone, how do I use it? How do I connect with emergency rooms and emergency departments? All that is kind of coming into play then now as the opioid epidemic unfolds and our justice populations increase in terms of the numbers that are being carried that have OUD, and that leads us right into the next bullet points, which is, do you consider for your jurisdiction where it's possible and where it's feasible? It does not make sense everywhere. You might not have the staffing to do it or the levels of clients to do it, but the idea of specialized caseloads. And certainly this is nothing new to probation and parole. It's nothing new to the courts, this idea of we have a large enough population and we want staff to focus. What I will offer, though, on this is, again, thinking and knowing that what we have is polysubstance users in the criminal justice population, that you think very carefully about whether or not you should do a specialized caseload, because all the other parole and probation officers might also have people who have opioid use disorder. It's just not showing up as their, what we often call their drug of choice, but it's there. And again, the heightened risk of overdose and overdose death that goes with opioids because of the physiological and neurological impact of it on the body doesn't mean that someone who's a marijuana user that's not sitting on a specialized caseload, if that person has in their background opioid use, that parole or probation officer and that supervisor needs to understand that, and those officers also need to have the same training as your specialized caseload folks. That seems kind of odd, but again, it's this polysubstance use issue that we deal with within the criminal justice population that really requires us to pay attention and think through. If we're going to do specialized caseload, what does that really mean about everybody else? Not the caseload, but about everybody else that we're supervising. What it does not mean is that they're in fact not opiate use disorder or at high risk, even if it doesn't seem to show up. Next, we turn to, and the slide's a little bit off, I hope you can see the top, I'll read it if not. It says recovery support services, housing and other supports in the community. Of course, these are the critical elements that go with what I often term the long run, right? The long run of getting someone successfully reentered, successfully into recovery, and on their way beyond when we're with them on the reentry side, whether it's court and probation or prison and parole, whatever it may look like, or immediately upon release, right? Folks who come out and have no justice supervision anymore, they're just being connected to treatment. These are the elements that go with it that fortunately in this day and age are getting much, much more attention on it. So we think about recovery and recovery support services. So recovery is sometimes, just have someone to kind of walk with you and talk with you as you move from year 1 to 2 to 3. Well, that's certainly part of it. There are services that actually go with this. And of course, those are called recovery support services. SAMHSA has a nice guide that allows you to do a quick scan of your jurisdiction and say, is my jurisdiction recovery friendly? I'd urge you to get that guide and look at it. It's just a bunch of check boxes you look through, and it lets you know, gee, I really need to kind of beef up on the recovery side, or yeah, we're doing okay. And of course, we're talking specifically to our population for recovery support services because they're generally outside the reach of criminal justice, so that they're not part of kind of our funding streams, not always kind of where we're thinking because they're 2, 3, 4, 5 years out. It lets you know how can we contribute to supporting and building out the recovery support system, but also where does that exist, because again, it's often out of the vision or the sight of the justice system. Housing, can we say enough about housing? No. We can certainly understand the limitations that exist in jurisdictions across the United States about our ability to provide housing, but yet the importance of it remains. And so if you're in a jurisdiction that you're really struggling with this, and that's a lot of jurisdictions, what you want to do is not give up, but to say, we've got limited housing stock. Are we using the housing stock for people in a priority order that makes sense based on our identification of people through screening and assessment of who is most in need of the housing? So we've got limited housing like everybody else does. How do we use that instead of saying, well, we just don't have enough housing, let's just keep moving on? Nope, prioritize your housing for those that are at the highest risk of opiate overdose and overdose death upon reentry, and those who are most in need of that housing to stabilize themselves, right? Because that's what housing is a stabilizing, just like medication-assisted treatment, stabilizing to reduce the cravings. Housing provides that, and we know that, right? So you think of the Housing First Initiative, which is Corporation for Supportive Housing, CSH, really continues to push out there and the good work they're doing. So on the first bullet point, I'd say go to SAMHSA's guide on taking a look at your community. Is it recovery friendly? On the second one, look at Housing First and the Corporation for Supportive Housing. The work that CSG has also done, of course, around this area. The third one is one you might not be as familiar with, but really is an offshoot that has developed out of the opioid epidemic in the United States, and that is the emergence of rapid response teams with probation and parole, and certainly within law enforcement. This is an area where I do a lot of national work and have expertise in, both on the parole side as well as the law enforcement side, and it is the idea that, again, with the opioid epidemic, because of the higher likelihood of overdose and death that goes with it, we want the ability to respond rapidly, hence rapid response teams, respond rapidly to folks and proactively when we can. So if you're in a community and you're probation, parole, and you're part of a reentry team and your treatment, you're part of this team, I would first advise a jurisdiction when I work with them to say, well, first let's go find out what your law enforcement, your fire and EMS are doing, because they're already set up for rapid response. And then what can parole and probation do to bolster that? What can treatment do to bolster that? And how do we link that in? that's a webinar unto itself, to be sure, but the idea is that when folks are in community and parole and probation have done their home visits, have done their searches, treatment, has seen the person, okay, what do we do about the other 22 hours for people who are at high risk of overdose and overdose death? And that's where the rapid response teams come in. It's about keeping a very, very close eye on folks in the first 2 weeks. You can identify them, again, through screening and assessment. It's not talking about everybody that's out there from reentry, a very subset of your population. And when I do this training with SAMHSA and help jurisdictions develop their rapid response teams, if you got 100 people that are reentering a month, you got to use your data to find out which of those 100, which are the 10 that your rapid response team needs to focus on, and then working with law enforcement and first responders, build that out, not from a criminal justice standpoint, but from a hey, we're here to save your life standpoint before anything happens. That's really what rapid response teams are about. So you use data to identify your folks, screening and assessment to get them to make sure they're at the right level, and then within the first 2 weeks, pay tons of attention to them through rapid response. It could be hourly, every 4 hour, 6 hour check-ins every day, going to their house, seeing them, calling them, and then it tapers down over time so that the rapid response team lets people go, and then they go on to, they're still part of regular supervision, but then they're intaking the new releases. And then finally, it is such a good day and age to see peers and the value and the importance of peer appears in the process that we do in criminal justice, because for so long we've relied, of course, just on treatment, which is good. Now we're relying on MAT, which is super good, and we are also recognizing and acknowledging and supporting the work of peers in the recovery support process. So if you've not already partnered with peers in your local community, I'm going to guess a lot of you have, please do so. But if you have, I want you to consider to make sure that they're part of your team, both pre-release and post-release, especially on reentry for this population, that they're known to your correction officers, they're known to your parole and probation, they're known to your treatment, which they should be, and they're an accepted and equal partner in the decision-making and in the success, and it's messaged that way and handled that way, so that the people who are reentering, right, say, okay, you're not my parole officer, you're not my probation officer, you're not treatment, you know, whatever, I don't really care what you say. They're saying, oh no, that's right, I met you when I was on the inside, I'm seeing you when I'm on the outside, and when I'm done with everybody else, you'll still be here with me. That's really, really the trick of peers. And then during the periods of time when they're struggling or moving from reentry to awaiting their first treatment day, 7 days out, if it's got to wait that long, the peer is right there with them, walking side by side. And the final thing I'll say on peers is make sure as you consider your funding, your grant funding, and how you build that out, think about peers and think about putting them in there, because we put lots and lots of stress on peers, and I know our networks in the U.S., especially because of the opioid epidemic, are getting very taxed right now because there just aren't as many as we need, but they're getting very taxed, and we ask them to do a lot of stuff for very, very little or nothing. So think about building your funding and your grants to include peers in that process so that they too can be supported, because you need them for the long run. When justice supervision is ended, you need them, again, reduce drug use, better life, reduce criminal justice contact, reduce crime. Everybody is safer, everybody is better off. So with that said, Mark, I will turn it back over to you for Q&A.
Thanks so much, Jack, and thank you for walking through the other best practices. And so we have a bit of time for questions and answers at the moment, and we have a few questions already. And I want to remind those who are attending the webinar to chat in through the chat box any questions that you might have. And so we have a few questions so far relating to medication-assisted treatment. The first question is, what are some of the advantages and limitations of using any of the 3 options for MAT in correctional facilities, and what are some of the practical considerations? Jack, do you want to take that one?
Sure. So, yep, am I good? No, I'm good. Yeah, you guys can hear me, right, Mark? I'm off mute. Good. Okay.
Yeah.
So the biggest one, I'm going to talk from a bigger picture perspective. The biggest one, of course, is costs, and that is in your jail or prison, what does your formulary allow? So when I said during the presentation, and what we know is that, of course, a patient, the individual, the client, needs to have access to all 3. That's really based on the doctor and the patient saying, okay, you'll be best on Suboxone, or you'd be best on methadone or Vivitrol. And yes, I know I'm using brand names and not endorsing any of them. That's just how we talk about them. And so to have all three options. So funding is the first thing. What do your formularies look like? What does funding look like to be able to pay for all three? And what does it mean if you don't have all three? It means you have one less medication available that might be the right medication for that person, where the other two don't work as well. So funding is a challenge. Then not having all three means, again, what I just said. You think about access to multiple medications. A lot of you on this call might have taken medication for a variety of issues. One medication didn't work as well, then the doctor, she changes up the doses you have, or she puts you on another medication for the same thing, and lo and behold, that one works. So funding, access to all three so that you get on the right medication that works just for you, individualized for you as a patient. Of course, with criminal justice, so we think about challenges and issues with diversion. And so what does that mean? Diversion means that the medication, especially on the inside, is taken by the person and used for something else and exchanged with other inmates or other folks in a custodial situation. What does that look like? That's certainly another challenge to it. But what I want to say overall, and then the fourth one is, I'm thinking of the community side now. The fourth one is, if I can deliver it on the inside, do I have the ability to continue continuity of care, the medication on the outside? And that takes a lot of work and a lot of effort at the highest levels of the agency, working with possibly the state Medicaid office, the county, your local healthcare providers, your local hospital, a lot of coordination to make sure that happens. So that, especially in the jail side, right, where we may do induction or continue them in, they're coming in from a probation violation, they're on medication in community, we need to continue that medication while they're in, and then when they get back out. So the coordination issues on the inside, outside are probably the single greatest barrier or challenge, I should say, in terms of doing this. Again, think of reentry going out, but what I said also, parole and probation violations, people coming in who are on the medication, should not be taken off the medication just because they're now in a custodial facility, especially jails with the churn where they're going to be back out. That on-off is a period of abstinence and then to use, and that is, again, that heightened risk of overdose and overdose death because of the on-off and the cravings return. So that's generally how I would answer that question right now, Mark.
Thanks, Jack. And then we have a question about access to naloxone. And so can reentry workers who do not work in probation and parole obtain training on administering Narcan and access to these drugs on clients? And a similar question is naloxone sold over the counter?
Yeah, so in the United States right now, in many, many jurisdictions and states, actually almost everybody can access naloxone right now. I know that, I believe it's CVS and Walgreens both have opened it up so that it's over the counter. Again, just look at your state. You can actually Google online. Just go to Google and search over the counter naloxone pharmacies, and you'll put it in, you'll get the list. There's actually a website that says which states have it and which don't, and you can look at that. So through standing orders that exist in states, through what the pharmacy companies, at the pharmacy, CVS and Walgreens have done in terms of making it available over the counter, through federal grants, state grants, local grants, naloxone is widely available right now to workers that are not law enforcement, not corrections, not parole probation, but behavioral health. It's available to folks in the community who want access to it. So there's lots of options to it. I can't speak for your county, your city, your state, but I can tell you again, just go to the web and search it, and you'll find, is there a standing order for your state that's been issued? The standing order allows then naloxone to be given out without a prescription in your state or in your jurisdiction. Is there a standing order? And then how much does it cost? And then what grants are available? And there's lots and lots of stuff on that coming down, including from the federal government.
Thanks, Jack. And then another question is there any perspective or research on outcomes responding to relapse, a strict versus relaxed approach or sanctioning policies, and specifically within community supervision?
Say that again, Mark. I think I'm missing your question. I know it's tough when you can't kind of access the person again in the crowd. Sanctioning and say that again.
Yeah, so what's the research on outcomes responding to relapse?
Okay. Yeah, go ahead. Outcomes responding to relapse. Okay. I'm going to take this generally. Again, if we have the audience here, I can ask a clarifying question. So if I'm a little bit off, I apologize to the person who asked it. What we would generally say, and I heard you say sanctions also, Mark, what we would generally say right now is, I'll use the phrase best practice, is that in the consideration of sanctions for folks who relapse, that you want to build your sanctions to account and accommodate for relapse as a part of a person getting to recovery, so that the clinical interventions that are needed based on their risk-need category, it's a very technical answer, right? Based on their risk-need category, that we're really relying on clinical interventions for addressing relapse more so than supervision interventions on relapse, with a population that is screened and assessed under DSM-5, and I'll use the lay word as being addicted, right? As being addicted. So the person who's not addicted and is not does not fall out on the clinical assessment as being addicted, their use of drugs is different than the population we're talking about here, which is a population that is opiate use disorder, polysubstance, remember that, opiate use disorder, DSM-5 severe, and so the response technically to that should be one that is really about clinical interventions primarily, with the supervision interventions on the lighter side. And so as to outcomes, the best thing that I would say is, yes, we have some research certainly that shows that works. You look at, like, for example, the drug court model, and this doesn't mean it has to be done within a drug court, not at all, as a matter of fact. What we're saying is that when we look at this population of high need and high risk, we have interventions that do work, that get good outcomes. And we know if we look at the BJA's residential substance abuse treatment, the RSAT program, which, if you're not familiar with it, is a modified therapeutic community done in a jail prison setting, I should say, combined with warm handoffs to community and community corrections and treatment and continuity of care, we get very, very good outcomes. But again, on the word sanctioning, because I heard that come up, treat this within the framework of clinical responses first before you're looking at supervision responses, unless there's some change in public safety that goes with it. But relapse has to be considered within that from a clinical standpoint more than a supervision standpoint for the person. So I think that's the best I can answer. So the outcomes, yes, we can show that there are good and there are better outcomes than not doing it this way, than using just supervision responses. Or saying, okay, you relapsed, we're going to now take you off MAT as part of that, and we're going to do something else with you. That's not a good response for someone on medication. By the way, speaking of this, what we also don't want to do is require that someone get off medication, MAT, as a condition of completing their term of supervision. We actually don't know a lot about that, kind of what the effect of that is, but it would seem to be that mandating someone to come off a medication that's there to help them stabilize wouldn't make a lot of sense. And we still see that happening on parole, probation, and even in court caseloads where that becomes a condition of completion, but that really kind of doesn't make any sense.
Thanks, Jack. Another question is, what are some approaches for persuading probation and parole or law enforcement to begin carrying naloxone?
Yeah, so that's a great question, and what I would answer it is just from the national work I do primarily in law enforcement, right? Because if that's where the lead on this generally has come so far in the United States. Only because parole and probation, right? They see the cases or the people after law enforcement has seen them, so that's no surprise that law enforcement has been really on the leading edge of this issue of naloxone. So the idea is that for folks who are encountering a challenge and need to change it, that's a massive driver. I can't tell you that if you had a probation department that really didn't have, and we work with these departments too, some who are on this call, that really don't have a high opiate use disorder population, that in fact they would have kind of that driver of change to say, well, we've got folks overdosing and dying at an increasing rate, the trend line's going up, and this is really impacting people's lives, it's impacting our officers, and we don't have that. So absent that, what I would say is even if you had one person and you could save one life by carrying naloxone, that's worth it. That's a life saved, and that's a family that gets impacted. Children, significant other, all those folks are impacted by that person's death. certainly for those communities, and again, this is where law enforcement is lead because they've been seeing it first, that have the overdose deaths that are higher than ever, that have situations that they're dealing with now. They're doing it once a month, or they're doing it 3 times a week or daily. That is the main driver of change of the rationale to say you need to carry naloxone because you need to save a life. So if you're not there yet on your caseload, just say, well, what if we could save 1 life? Is that enough for us? If the answer to that is yes, which I think it should be, then that's your motivation to change. If you're not in that, if you are in that space, absolutely it makes sense. What I would also offer then is as good parole and probation, as good behavioral health providers, as good folks working in this field in this day and age, it really, I think, carries kind of a judgment call to say, so we're in an opioid epidemic and you're not arming yourself with all the tools needed, no matter how often you might use it or not, to deal with this. And that's really odd. So in my work, I carried a weapon for many years as a state level state parole officer, and you know, how many times do you use your weapon? Well, that's not the point. The point is you have it, and when you need it, you have it available. Same argument for naloxone. If you're not seeing a lot of it, the point is when you need it, you have it, because it's too late at that point otherwise.
Thanks, Jack. And then some other questions relate to building up connections with specialty courts. And so one question is, how can I build up a better connection with the court? I've worked as a recovery coach in the behavioral health court in another county.
Yeah, so that's great. And what I would tell you that the courts, through probation, through the judge, through the prosecutor, defense bar, whatever it may be, right now in this day and age should be really, really eager to have folks from the recovery community be engaged with them. So as a general process, this is going to sound kind of funny, I'd say take them out to lunch, because I always tell people to take people out to lunch, because when you're sitting over food, it's kind of hard to be disagreeable. But on a more serious note, you know, this really is what should happen at an organizational level. So great motivation on the person who asked the question, talking about themselves and their work, but organizationally, the presiding judge of a jurisdiction should be reaching out to the behavioral health providers, the recovery community, and saying, let's do lunch together. I'd like to talk about how we can work together. And if that's not happened, the behavioral health leadership and the recovery community leadership should be reaching out to the chief of probation and the presiding judge at the organizational, at the systems level, and saying, can we have a conversation about how we might work together? So the simple answer is sit down and have a meal together, but what I don't want you to do is just do it individually. Do it from a leadership, organization, system standpoint. That way the work of recovery in the courts and treatment and law enforcement and prosecutor and defense can be done together, collaboratively. And by the way, the research shows in many areas that when you do things collaboratively, systemically, your bang for buck proposition goes up, because you're bringing more resources to the table at the right place and right time than you can do individually. It makes sense intuitively, but it's also a lot more work and effort to do it, and so I get why more people kind of don't start out that way. But the best thing you can do is, if you're the head honcho, go see the other head honchos. If you're not, get your head honcho and say, I'll do the legwork on this, but I want you to make this phone call, send this email, and then we'll go see the chief judge, and we'll sit down and have a conversation with her and say, how can we be part of your effort? And then show them why, right? Show the value of why based on statistics. Recovery supports long-term success for the individual, less crime, crime reduction, safer communities, less victims, all the things that I talk about all the time about why we're doing this work.
Thanks, Jack. And another question is it possible or desirable to give Vivitrol prior to leaving prison when community treatment is not yet set up? Hey, Jack, do we still have you?
Mark, I apologize. I could not hear the question. I could hear just about every other word, so I apologize. Can you try that again?
Yeah, no problem. So the question was...
Yep, you do now. That cut out for about 30 seconds. I apologize for that. Yep.
Yeah, no problem. The question was, is it possible or desirable to give Vivitrol to someone before leaving prison, even when community-based treatment isn't set up yet?
Yeah, so first let me say this, I'm not going to advocate for a specific medication. I use like the terms Vivitrol, Suboxone, just because those are known names. So what you're really talking about is, should we be doing pre-release induction if there's not the ability to do continuity of care right away? So the first answer is you got to correct that continuity of care. That's the big thing that has to happen first. Now, does that mean that you can't release people? No, you release people when it's time for them to be released, and you work with what you have, but you really first need to correct that. You need to get that fixed so that there is continuity of care. So then, what about pre-release induction for use of MAT in that category? Here's what we know right now is that it's promising. In fact, the Bureau of Justice Assistance through COPE, the Comprehensive Opioid Addiction Program, is going to be doing a webinar on this coming up very soon. I believe it's August 9th, but we can check that date and get that out to folks on MAT practices in the United States. And then RSAT, the Residential Substance Abuse Treatment, another BJA grantee program that's open to all, just like COPE, has done quite a bit of work in this area. What we know is that it does help. We don't fully understand kind of the measures around it, but we know it does help. Again, why? Because it reduces the cravings and everything else the person is facing upon release. Reducing the cravings is a big deal, right? They have anxiety, they have fear, nervousness, uncertainty. Cravings on top of that is just a multiplier of negativity. So we believe that this should be a practice that unfolds more and more in the United States. The challenge is then, of course, if you don't have treatment, of course, that follows it, what does that mean and how do you deal with that? And this is a place where peers might come into play. Again, building out your continuity of care, both your behavioral health treatment as well as accessing the medical community, your doctors, your hospitals, where folks are who can prescribe more MAT, right, if you're just doing the pre-release side. But really then what we'd say is, sure, it would seem to make sense because upon reentry, you're helping that person have one big thing less to deal with, but it is still the continuity of care you want. We just don't know beyond that, though, kind of what the implications are of it. But if people had to say, if I had to work with a jurisdiction, say, should you do it or not, I'd say, yes, do it. In the absence of releasing someone who will then face a heightened risk of overdose and overdose death and have no help for their cravings, have nothing to work with other than hopefully they got something, treatment while they were in prison and jail. Nothing versus something, I would take something, but again, be aware of the safeguards that would then be needed so that when they get to that point of the injection being wearing off, that they're now at that point of, okay, now they're being released again. Once when they're released from the facility, and then once as around 30 days, give or take, that the medication is beginning to wear off. That's kind of another reentry point is the best way to think about it. What are we going to do about that? Do we have the ability to continue MAT with a medical practitioner? Do we now have the ability to put peers as a stopgap measure in between until they can access care? So a lot of things to unpack on that one, and with the time we have now, I think I'll kind of stop there.
Thanks, Jack. We'll do about 2 more questions, and then we'll go ahead and wrap. So another question is, when using peer recovery support specialists in probation and parole setting, is a release of information or consent form necessary for the individual to communicate with the peer, or for the agent to discuss any info with the individual or with the peer?
Mm-hmm. It's a good question. What's often called the HIPAA hand grenade always comes up, right? There's good ideas, good things being discussed, and someone says HIPAA and throws in the HIPAA hand grenade, and everybody stops talking about it. So here's the best way to think about it, is certainly the person and the peer can discuss whatever they want. That's the individual to the peer. HIPAA really is about protected medical information being discussed outside of that. So should parole and probation have a release? Yes. Sign a consent. Just have it signed and include the peer in that. Will the person want that? That's entirely up to that person. But what I generally say is do the consent. There's no harm. There's no foul to it. It allows the team effort that's needed for reentry, right? Successful reentry is best done in a team collaborative approach. And so get the consent signed, have your lawyers draw up the form, and include in that the peers so that they are able to be part of the ongoing case management conversations. But certainly once supervision ends, then the person and the peer are left alone. There's no more criminal justice supervision. There might still be treatment going on. That's between those two people. But otherwise, I generally say yes, get a consent done and include the peer in it, include treatment in it, and that allows you to do the collaborative approach. Each jurisdiction kind of looks at this stuff differently, not that HIPAA is looked at differently, but in terms of where those boundaries are for them. But the easiest thing to do is to do the consent pre-release, get it done at that point, get everybody in, and then on the post-release side, as you add or change kind of your team that's working with the person, go back and look at the consent and see if we need to do a new consent or an updated consent form. But I always lean on that side to do it that way, and that keeps everybody protected. HIPAA, though, is not designed to limit the amount of work we do to help someone get into recovery. So think about it as just kind of a safe space and a safe way to do recovery, to do supervision work. It's not meant to limit our ability to help the person. It's just meant to limit what we say to whom we say it, but it should really be thought of as a resource to keep us safe, not a wall or barrier that stops us from saying, well, I can't say this, so therefore I can't communicate that to somebody. If that's the case, have your lawyers go back and look at the consent you've drawn up and say, I really need to share this information with the peer specialist, or the peer specialist needs to get this from treatment. We need to look at our consent form and open that up, because that's what gets us to better care and to get the person in recovery. So a little bit extra added on to the end. If your consents are constraining your efforts on information that everybody can clearly see you need to share, sit down with the lawyers and have them look at it and say, how can we open this up? Again, the point is to help the person get to recovery. It's not to build a wall that stops us from assisting the person.
Thanks, Jack. And then one last question is, how do we bridge education practices to assist individuals with opioid addictions so they can access employment?
Yeah, so this is a tough answer. What I mean by that is the areas we work in where you have high rates of opiate use disorder, and certainly with overdose and death, you must engage the employers who, by the way, might be well ahead of this because they're looking at their workforce, and in areas that are really hard hit, they're looking at their workforce and saying, I've got to have different strategies on board because I have to keep my workforce for my company to keep running. And so this is a huge opportunity for parole, probation, for behavioral health to engage employers in conversations about, we understand that because of the opioid epidemic, because of substance use disorder, your workforce might be subject to churn at higher rates as your drug testing policies or your insurance coverage just can't handle this. How do we work together, employer, so that we can have a relationship that allows our folks on parole and probation to be employed, to pay taxes, which, by the way, right, there's research that shows that's part of recovery. When the time is right for a person to have a job and when it makes sense for them to have a job and be in that space so they can hold it, what is it that the employer can do so that their company can provide support and services for them? It is now not unheard of at all that employers, especially in hard-hit areas, Midwest of the United States, just to take an example, are looking at their drug policies very differently because they need to retain workers. And they're asking their insurance companies to put on more funding for employees who need to access drug treatment instead of before, you just get fired, or you have 30 days to do this and then we'll fire you if you're not clean. More and more now employers are saying, I need my workforce, I need them to be here, show up every day. So it makes sense for me to have a drug policy that says, okay, you've tested positive, if there's no danger to the equipment you're using or the machinery or to the type of business I run, our insurance policy and our healthcare now, I should say our insurance is in healthcare, our healthcare now provides for an expanded support for treatment access for you. And then parole and probation, how can they combine their resources to help that so that their folks stay employed while still engaging treatment? You need to hear that, while still engaging treatment, while meeting the standards of and conditions of supervision, but also are able then to continue on. Certainly 10 years ago, if you tested positive, lots of employers would say you're done. Now that is not as much the case again, especially in areas that have been hard hit. employers are saying, I need to keep my workforce, what do I need to do? Parole and probation and behavioral health are in a really good spot to work with these employers. The arrow goes both ways. And going back to the HIPAA question, this might be one where there might be some HIPAA issues that lawyers need to look at in terms of working with an employer who otherwise might not actually have any right to information about what's going on with the person, but to keep that person employed, engaged in treatment, properly supervised, safe to the community, we might need to engage them in the HIPAA conversation and have intentional sit-downs beyond what used to be, which is, hey, employers, will you hire Jack? Now it's employers saying, I'd love to hire Jack. We need to have a conversation because I'm going to invest money into hiring him, into training him. Love to have him. He's a great worker, but I got to make sure, knowing his background, that we have the ability to keep him here. Parole and probation, behavioral health. What can you do for me? Not just what can I do for you, and how do we work together?
Great. Thank you so much, Jack, for fielding those questions. And just to wrap up the webinar, I want to go over a few more slides. So this slide here lists some key resources on 3 main topics: on finding prescribers for medication-assisted treatment, best practices for medication-assisted treatment, and at the bottom is a link to the recording of the webinar we did on July 10th on screening and assessing for opioid addiction in the criminal justice system. And then this slide has contact information for myself and for Jack. And so if you have additional questions that weren't answered on this webinar, feel free to email either Jack or me, and we'll be happy to follow up. And then just a reminder to join our distribution list and sign up for the National Reentry Resource Center's newsletters to receive information about upcoming webinars, funding opportunities, and news in the field of reentry. So this webinar should be posted on our website by the end of next week. And also at that time, the fact sheet on best practices should be published as well. So lots of resources to look forward to. I want to thank Jack and Andre so much for being panelists on the webinar, and thanks to everyone who attended the webinar today. Thanks so much and have a great afternoon.
Goodbye. Thank you.